So is Dr. Vikas Sharma over here? Please do come, Vikas, and give your presentation. He'll be talking about sutureless and glue-free limbal conjunctival autografting in primary and second recurrent pterygium.
Yeah.
Great.
Good afternoon, everyone. This is my topic of presentation. So, as we all know, pterygium is the subconjunctival fibrovascular growth which comes over to the cornea. It has multifactorial etiologies, but UV exposure remains the significant one. Treatment modalities are mainly surgical, however, recurrence is the leading cause of surgical failure. The purpose of our study was to evaluate and analyze the outcome of sutureless glue-free limbal conjunctival autografting after excision of pterygium in cases of primary as well as recurrent pterygium. So my study duration was 1 year. The study was conducted at a tertiary eye care center in Delhi. It was a prospective interventional study. We recruited 70 patients, out of which 45 were having primary pterygium and 25 were recurrent pterygium group. We did Wilcoxon match pair test and Mann-Whitney U test for comparative statistics and independent sample respectively. The p-value of less than 0.5 was taken as statistically significant. We included all patients of all age and either sex with primary as well as recurrent pterygium, and these are the exclusion criteria. The goal of our surgery was to complete excision of the pterygium with restoration of normal conjunctival anatomy with the help of the graft and to prevent recurrence. These were my outcome measure. My primary outcome measure was recurrence of the pterygium, and we defined recurrence as any fibrovascular regrowth across the limbus. My secondary outcome measure were graft-related complications and change in best corrected visual acuity. This particular slide shows the mean age of the patient in both the groups. This is the sex distribution. In both the group, male preponderance was more, and this is the outcome measure. Our primary outcome, we noticed 2 cases in the recurrent pterygium to be having pterygium. It was 8% of the total recruited population in the group 2, and these were the graft related complication. We noticed graft edema was the most common complication, and in 7 and 4 in group 1 and group 2 patient respectively, and 2 and 3 patient was having graft retraction in the group 1 and group 2. We did not notice any graft loss, and 2 patients in recurrent pterygium group developed tenant cyst. There was a change in best corrected visual acuity was not statistically significant in both the groups. This is my master chart. Coming to the discussion part, we had 2 patients, total 8% of the population in that group 2 patient which found with the recurrence, and which might be attributable to the inadvertent inclusion of the tenon in the graft or because of the aggravated tissue response due to the younger age of the patient. The main disadvantage of sutureless glue-free technique is the risk of graft loss. To combat that, we advise to patch the graft for at least 48 hours post-surgery for better adherence and minimize chances of graft edema. To conclude, sutureless glue-free limbal conjunctival autografting is a safe, effective and economical and less time-consuming procedure, not only in primary pterygium but as well in recurrent pterygium as well. Surgical outcome following this particular surgery are comparable to most commonly performed suture limbal conjunctival autograft, and it gives less patient discomfort, better patient satisfaction, but a randomized multi-center trial with a large cohort and longer follow-up warrants to substantiate our finding. It was a pilot study. These are my references. Thank you.
Thank you, Dr. Vikas.
Dr. Vikas, you've taken autoconjunctival graft, right, from the same
that's
eye.
correct,
So what
yes.
is the position you normally choose from?
We take it from inferior-temporal quadrant, ma'am.
Inferior-temporal quadrant. Any particular reason?
Superior we generally want to avoid.
Okay.
Inferior temporal, do you think more chances of infection? And one more point,
Yeah.
48 hours we will be patching.
Yeah.
So how do you?
We did it under ointment moxifloxacin, ma'am. The
Okay.
patching for 48 hours.
But there will be always a small fear that infection.
Yeah, because inferiorly.
Okay.
You did these surgeries under block or topical?
No, it was under blocks.
Under block.
Yeah.
If I talk of patient's perspective, I have experienced faculty here. So, patching somebody for 48 hours, how would be the response from the patient rather than opening the patch after 3 hours or 4 hours and putting 2 sutures on the graft or 4 sutures?
We have done, kept it for 2 hours, 2 days, yes. But not always, it's not, I would say that the patient is compliant 100%. Patients are not compliant.
Just the
But
patient's
still,
perspective.
most of them are compliant. If you can explain it to them that a suture would create a foreign body sensation later on, so we've just lift your graft with the glue-free and sutureless. So I have convinced patient. But then he said he didn't lose a graft. That's one thing. We lost a graft. That's very surprising because that is how we kept, and I had 2 instances where the graft was lost. Patient did not comply to us. Although when he came back, he said he did comply.
Yeah.
But it opens up. So
I think
things
it's a
happen.
personal preference.
It's a personal preference. It's
Okay.
some patients do
Usually
comply
I
well.
do sutures, and people, they say for 1 day or 2 and just give copious lubricants and maybe a ointment at bedtime, a gel at bedtime.
Yes, of course.
People
That
are
is how
happy.
we were I was doing the same thing for
Yeah.
years together. But now with this fibrin, we just use the
Okay.
auto like serum of the patient and just
Yes.
put a bit and just stick it up. So that does give very good results. This
So
is
you
one.
patch for a day?
Yes, 48 hours. No, 48
48
hours.
hours.
48 hours minimum.
Okay.
That's the thing. That is what I said. That not that 100% patients are compliant. This is one thing, and one more thing I would like to ask you about the graft. Did you mark the
We did
limbal
mark,
area,
yes,
and
yes. We
did you
did
do
mark,
it?
ma'am.
Did you turn it, and
Yes.
did you do anything of
Yes.
that sort?
We did mark with the help of the die. In
So,
fact,
and what is
that
the size
marker-
of the graft that you took?
We
Is
were,
it the same universally,
no,
or
no.
do you mark it according to the size of the pterygium?
We size of the excision, ma'am. What we
Yes,
get
that is
after
what
the
I-
excision, and we were marking 1.5 to 1 mm more.
Correct. Yeah. Okay.
Thank you,
so-
Dr. Vikas.
Yes.
Doctor, I just want to ask you one thing, like how long you have done the follow up, because I have seen with the blood, like it dislocate even after a week also.
Yes, ma'am. We took follow up for a year, ma'am. 12 months post surgery.
So it was intact, all the
Yes, ma'am,
cases.
absolutely. And after a few weeks, you can't even see the graft. It is that clear.
I think 1 year was not needed.
That's true.
We were doing it for the recurrence, ma'am.
Okay. You
The
have good
main thing
patients, they
that you
come till 1
pointed
year.
out very well is the edema of the graft.
Yes, ma'am.
This is the part where we really have to counsel the patient,
Yes.
because of the clot or whatever is below, the graft is edematous, and the patient keeps on complaining of
Yes.
that redness around that.
That's
So
correct.
that's one thing
And
which
what
is
happens is if we
you
don't
really
patch
have
it
to
for
do a very
longer
good
duration
counseling.
of time, the graft swells up with the surrounding
yes.
whatever fluid is there. Also, if we start immediately the drops after 24 hours, then that drops also goes behind the graft and it swells up.
Absolutely. Thank you so much. Yeah.